So we finished up our last presentation talking about intraoperative care. And so we're going to move into postoperative care. And when a woman has a C-section, typically she's going to have 96 hours of care in the OB unit. So with a vaginal delivery, she has 2 days. With a C-section, she typically has 3 days. Sometimes they can stretch it out into 4 if she's having pain control issues or maybe infections, something else like that is going on. So when you look at these interventions, all of these should be very familiar to you, with the exception of doing fundal checks. And so when you are in a labor and delivery, you want to add those fundal checks with vital signs. So every 15 minutes for the first hour. If that's stable, you can go every 30 minutes for an hour, then hourly for 4 hours, and then move to every 4 hours for the first 24 hours. We do want to be monitoring her catheter. They will have a catheter for 24 hours, so ensuring that she is having adequate urinary output, which would be at least 30 ml an hour. Promote bonding, pain management, gas relief. Early ambulation is really going to be important. Once she has full sensation returned after her spinal anesthetic, we want to get her up and get her moving. So this again talks about what you will be required to do as a nurse. As far as maintaining NPO status, that kind of depends on physician preference. Some physicians will let her start having just ice chips and sips of clear liquids. Others may wait until she is actually passing flatus, so listening to bowel sounds, asking her about passing flatus. With respiratory assessment, when a patient has a spinal anesthetic, you need to monitor respirations every half hour for 6 hours and then hourly for 6 hours. So ensuring that you are monitoring those, getting that documented in her electronic health record will be very important, and then assessing need for any additional pain medication. When you are looking at her assessment, typically the dressing will remain on her abdomen for 36 hours. The physician will usually remove that, and then it's left open to the air. So you may see staples as shown in this picture, or you may see steri strips intact. But when you're doing this, use the RETA assessment. So assess redness, edema, ecchymosis, drainage, and approximation. I touched a bit about VBACing when we were talking about inductions. With a vaginal birth after cesarean, what we would like to see in order for a VBAC to occur is that the woman is in spontaneous labor and that her cervix is favorable. That's when we're going to see our most successful VBAC rates. You can request a trial of labor to see if we can get our patient to complete and have a successful vaginal birth. The thing that we need to remember is that you need to have a surgery on standby in case something goes wrong. When you are doing a trial of labor, make sure you pay very particularly close attention for hyperstimulation. We do not want this woman that has a uterine incision to become hyperstimulated and increase the incidence of either placenta abruption or rupture of the uterus. So we do see decreasing capabilities of VBACs in smaller facilities, but our larger facilities where you have surgery in-house and you have an anesthesiologist available, you will probably be seeing VBACs much more frequently there. So here's some indications listed out up here for you. If you have questions about them, please let me know. Contraindications: we don't want to use cervical rightening agents such as your Cervidil or Cytotec or balloon, the Foley balloon, because that could mean that her cervix is not, that means her cervix is not favorable and it's not likely that she'll have a vaginal delivery. 2 or more previous C-section births, intra-delivery interval of less than 24 months, meaning it's been less than 24 months since she's had a C-section. Advanced maternal age, fever, or cephalopelvic disproportion. If she has had a baby that is large for gestational age and not able to deliver, we don't want to chance those risks again. Other things that you may come in contact with: DIC, disseminated intercoagulopathy, is listed out up here. This simultaneous clot formation and anticoagulation in the body. When we see DIC occurring, we often see that associated with HELP syndrome. We see it with preeclampsia, eclampsia, and the uterine scar where the placenta was is a wonderful place for a woman to bleed out. So we need to be aware of and be cognizant of those. We're going to talk about anaphylactoid syndrome of pregnancy, ruptured uterus, shoulder dystocia, and then post-term pregnancy and delivery. So with DIC, really, I talked about the clot. So that large clot on the placenta consumes all the clotting factors, and then the woman is not able to clot in other areas, such as if she has a Foley catheter, any IV sites, those types of things. So we might see bleeding from the mouth, nose, any incisions. So really the thing that we need to do is try to replace blood and clotting factors, but then move to a C-section to remove the cause of the DIC, or if it is due to the placenta site, she may have to, in fact, end up having a hysterectomy. This information is found in chapter 14 of your textbook. The anaphylactoid syndrome of pregnancy is on page 522 under emergency care. This lists the signs, interventions, what we want to see occurring. When we're talking about anaphylactoid syndrome of pregnancy, oftentimes it's obviously going to be emergency to save the mother and the fetus's life. So we do prepare for emergency birth, but your signs are listed out up here as well as interventions that you will be doing. Oftentimes, our maternal fetal success rates are really poor with the anaphylactoid syndrome of pregnancy. With a ruptured uterus, we see this occurring in multiparous women or women that have had prior C-sections. So you can have a complete or incomplete ruptured uterus. The signs and symptoms are listed out up here. Pain may or may not be present. We do see fetal distress as common because with a ruptured uterus we have decreased placental perfusion. Women complain of something giving way, something ripping. We see hyperstimulation or tachysystole, as you can see down here. So what we want to do is prevent a ruptured uterus from occurring. So being cognizant of those women that are at high risk for ruptured uterus, prevent hyperstimulation if we are inducing or augmenting labor, having IV fluids going, transfusing with blood products, and then prepare for immediate surgery. Shoulder dystocia is a very common maternal problem. If you look at figure 1913 and 1914, you can see additional information and photos. With a shoulder dystocia, what is occurring is that the head is delivered, but then as you can see in this picture, the shoulder does not pass through. This is an obstetric emergency because if the baby were to get stuck in this position, you would end up having fetal demise. So risk factors: macrosomia, meaning a large baby, and then also history of previous shoulder dystocia. So my rule of thumb is once a dystocia, always a dystocia, so we do want to be very cognizant of those. Management is going to be suprapubic pressure, which is not pressure on the uterus or the fundus. It's directly on top of the pubic bone, so where those pubic bones meet, right at like the top of the mons pubis. McRoberts maneuver, which is shown in this picture, so we bring her knees all the way up back by her ears, and that helps to shift the pelvic inlet and open that up. Make sure you do not use fundal pressure because that could lead into rupture of the uterus. Signs that you might see shoulder dystocia occurring are slow progress of second stage labor, formation of a caput that increases in size, the turtle sign, which is the head goes out, that when she's pushing, the head comes out, and when she stops pushing, it goes back in. And I don't mean all the way out. I'm talking about like during the crowning phase. So that would be the turtle sign. And then when the head is delivered, external rotation doesn't occur. So things to be very cognizant of. And then lastly, post-term pregnancy and birth. with postpartum pregnancy, sometimes it can be misdiagnosed because we're unsure of the female's last menstrual period. If she has delayed prenatal care and she's unsure of her dates, so clinical manifestations. Remember, when you think about that last trimester, there's oftentimes a slight weight loss. So if you're continued to see maternal weight loss, decreasing uterine size, meconium stained amniotic fluid, advanced fetal maturation. So when the baby is born, are you noting deep creases, absence of lanugo, no vernix caseosa, those types of things. So what will happen is that the baby does continue to grow, and we can see dysfunctional labor and birth trauma due to the size of the fetus. And then with the fetus, a lot of times the labor is very long. We can see shoulder dystocia due to fetal size, and then asphyxia from macrosomia. And then as the placenta ages, it tends to die in places, so we see decreased perfusion that way, and that does cause compromise in the fetus. So what we're looking for are weekly antepartum fetal kit counts. So when mom is at home, she's 40 weeks gestation, she needs to be doing daily fetal kit counts. She needs to be coming in for weekly NSTs, looking at the amniotic fluid volume, contraction stress tests, biophysical profiles. Those types of things are going to be important. So please come to class prepared with questions that you may have over this lecture, and good luck on the exam.